Good morning. We are live. I thank all of our BCCPA 2020 conference delegates for attending this week and joining us for one of our final sessions, which is focused on the experience of the COVID crisis in British Columbia. I would like to acknowledge that we are meeting here today on the traditional territories of the Coast Salish people. In addition, a big thanks goes out to our title sponsor for this conference, Handicare. My name is Mike Klassen. I'm the Vice President of Public Affairs for the BC Care Providers Association. I have also served earlier this year, prior to our new CEO Terry Lake coming on board, as acting CEO during some of our sector's most difficult months in our history. We recall how each day during the month of March, we were shocked by how quickly the novel coronavirus impacted everyday life. Then we heard the agonizing stories of how the virus spread through our long-term care and assisted living residences. The first SARS-CoV-2 outbreak in Canada happened here in BC at Lynn Valley Care Centre, where on March 8th, we had our country's first fatality due to COVID-19 in a care home. Only a day before, Dr. Bonnie Henry, BC's Chief Medical Health Officer, had wept at her podium during a news conference, responding to a question about the vulnerability of our seniors in care. COVID-19 clusters quickly appeared in several sites here in BC, including in long-term care, assisted living, and independent living homes. Over time, we saw SARS-CoV-2 outbreaks in acute care hospitals, as well as government-owned and operated, private, and non-profit long-term care residences. Canada's media painted the outbreaks in our seniors' care as a national shame. The response to COVID soon became our sector's biggest ever crisis, and the reporting was withering as the public looked for someone to blame. This pernicious virus did not distinguish between sites based upon its funding model, however. Residents for for-profit, non-profit, and government-operated, unionized, non-unionized, private pay, or government-subsidized sites were all susceptible to the wrath of the virus. If there was an early pattern, it was that the virus appeared to spread more quickly in older buildings with multi-bed wards, narrow hallways, and cramped dining rooms. In other jurisdictions, such as in Ontario and Quebec, the spread of infection was much more severe, leading to fatality rates that were orders of magnitude larger than in BC. While the Canadian military was deployed in care homes in those provinces, BC care homes were thankfully spared. It was not just at the building itself that could determine the severity of the outbreak, but also the availability of personal protective equipment and the level of know-how needed to keep staff and residents safe from infection. Then there comes the question of staff itself, whose heroic efforts providing long hours of care and companionship for residents were ignored as the public cheered on their healthcare counterparts in hospitals that were half empty to prepare for a surge that never arrived. Swift action to require staff to work in a single site shone a light on what care home operators and organizations like ours have been saying for years. There are simply not enough staff. The single site order from the provincial health officer determined that in BC, nearly 9,000 staff were employed at more than one workplace. By requiring that staff stay at one site, many lines required significant overtime to make up the shortages, leading to higher costs and worker burnout. These are the conditions that existed while our heroes on the front line did everything humanly possible to keep COVID-19 from getting in our care homes. Yet, the curve also seemed to bend here more quickly, leading many to believe that BC was a relative success story in Canada, which is why when this session was planned, we wanted to ask what were the ingredients of that success. Today, however, with spiking rates of infection in BC, can we still point to our province as a success? We have three extremely qualified panelists to help us here to answer that question and get a real understanding of where we've been during the COVID crisis and their ideas on what lies ahead. I'm pleased to introduce Dr. Roger Wong, who is Vice Dean and Clinical Professor, Division of Geriatric Medicine at the Faculty of Medicine at UBC. In addition to his impressive credentials that you can view on his conference bio, Dr. Wong has frequently engaged with BC Care Providers Association. Roger has been a sought-after interview subject on local and national media and an advisor to governments on how to address the systemic challenges faced by the continuing care sector. He was recently elected to the Fellowship of the Canadian Academy of Health Sciences, one of the highest honors in the health sciences field in Canada. I would also like to welcome my friend and sector colleague Jennifer Lyle, Chief Executive Officer of Safe Care BC, our sector's finest occupational health and safety organization. Jennifer's unwavering leadership during the COVID crisis has caught the attention of many in our sector, and she managed to make it happen as her lovely children made mischief behind her during many Zoom conferences. Jennifer led her team in a rapid realignment of operations, including the launch of a province-wide PPE initiative, Operation Protect, which we'll discuss shortly. Finally, I'd like to introduce Dr. Michael Schwant, Medical Health Officer with Vancouver Coastal Health and Clinical Assistant Professor in the School of Population and Public Health. Michael has himself emerged as one of BC's most noteworthy health leaders during the COVID crisis, in part for his strong communication skills and talent for making good Twitter threads happen. Regrettably, because of the election call this week, we were unable to be joined by Kirsten Fisher, the Executive Director, Senior Services, in the Specialized Services Division at the Ministry of Health. I can only speak to the incredible contributions of Kirsten and her ministry colleagues during our health crisis, and she sends her regrets on not being able to join us here today. So now that we've set the stage for our discussion about COVID in BC, my first question goes to Roger. Roger, how do you believe overall the long-term care sector in British Columbia has responded to the COVID crisis? And going forward, what areas do you think are going to need improvement?
Thank you very much, and good morning, everybody. I have to say that these are very challenging times that are evolving very rapidly. As I reflect back in terms of how the long-term care sector and seniors in general in British Columbia have been affected by the COVID-19 outbreak, I have to say that I continue to remain quite concerned. Concerned because seniors and their loved ones are affected. I mean, let's face it, they are facing a double burden. They have the burden of having their social constructs disrupted as a result of the pandemic. And at the same time, we know that seniors, in particular those including the most vulnerable in long-term care homes, are disproportionately affected in terms of deaths resulting directly or indirectly from COVID-19. I would say that everybody in the province, all the way ranging from healthcare providers, our frontline workers, and everybody has been working extremely hard in trying to protect and support our seniors. And let's not forget about their loved ones and their families as well. We know that there are many lessons that we have learned in the beginning months of the pandemic. I remember vividly that weekend in March when the World Health Organization has just declared the coronavirus illness as a worldwide pandemic. How stressful it is for all of us working in the front line, in the field, and trying to support seniors and their loved ones. I think that some of the lessons learned that we need to really focus on as we face future waves of the pandemic include things such as how do we best support the people who are actually working in the sector? How do we best support seniors and their loved ones, not only by physically protecting them from contracting the virus and developing serious health complications, but also the social aspect. Mental health is just as important as physical health, and it is important to make sure that seniors and the loved ones stay connected in the middle of the pandemic. Compassion is really important as we try to connect with each other. And last but not least, there are systemic issues that are revealed by the COVID-19 pandemic that all of us, including leaders, as well as our government and ministry colleagues, both provincially and federally, must take action right now because the time to act is now.
Thanks very much, Roger. You talk about the family issue among the many points that you made, and I really want us to do a little bit of a deep dive a little bit later on about that topic. I'm going to go to Michael Schwant now. Michael, I'm going to pull up a tweet that you did back on May the 5th. And I remember this one specifically because I found it very heartening. I said that it's very hard for people in the public to understand what was really going on, the kind of the strain and the amount of work that was going on in terms of trying to deal with this virus, the crisis that was unfolding before our eyes at that time. And you did something that I thought was very unusual for a public servant. You came and you used the Twitter medium to really describe what was happening in terms of the outbreaks and how your colleagues were responding. I don't want to spend too much time talking about the tweet itself, but I do think communication is very important. And so from your perspective now, with a few months distance, how do you think you and your colleagues at Vancouver Coastal Health have responded to the COVID crisis, and what were some of the better points, I guess, in terms of the work that you did?
Well, thanks very much for that, Mike. And I think that it was heartening for us sharing some of our early findings with long-term care COVID outbreaks and seeing the response, the positive response from across Canada, and in fact, practitioners around the world to some of the actions that were actually helping and actually working. As you've noted, we had in BC some of the first cases of COVID-19 in the country, the first large outbreaks in a long-term care facility, and unfortunately the first death in a facility just days before the pandemic was declared. And while a lot of effort had been directed appropriately to bracing the acute care health system or hospital system to avoid being overwhelmed during waves of COVID-19, the long-term care sector has been perhaps less prepared, although we did have hints internationally from Italy or from neighbors to the south in the United States that this was an area we would need to watch very closely. And I think that some of the successes that we've had in Vancouver Coastal Health and in British Columbia more general included the ability to rapidly pivot our attentions to bring the very same infection prevention and control experts, medical microbiologists, public health officials who might normally be directing attention to hospital infection control to work in these long-term care centers. So we were able to not only tell long-term care homes what to do, to direct them and give them that technical expertise, but to be right there with them, to have daily meetings on site with them, with all of the people that were needed. We were able to develop regional operation centers that could respond to their needs for personal protective equipment day to day or even hour to hour in some cases to make sure that they were well supported. So often people ask, what were the main innovations in British Columbia in terms of managing long-term care outbreaks of COVID-19? And I really think that the main outbreaks lay in those partnerships in between these different roles. And although this has been a new pathogen that we continue to learn about, its transmission, it remains very challenging. Its symptoms in older adults are very challenging and quite varied between people. We do think that we've been able to innovate within our system, and I'm glad to have the chance to talk a little bit more about that today.
Thanks, Michael. I have to say that having watched closely what Vancouver Coastal Health did and your colleagues such as Joanne Tate, the fact that you were well ahead of everybody in terms of moving to single site was, I think, a critical piece. That happened weeks before the official provincial order on that one. I know it took some leadership to bring that together, but also what's been very impressive to me is how quickly you got on site. I know that the Lynn Valley Care Centre story erupted as being some sort of attempt at trying to create a scandal there. But when I followed the timelines, you guys were on that site within hours. You were communicating with staff, and you were dealing with a very challenging situation where somehow staff had been convinced not to come in, and as a result, you had to bring a lot of bodies into that site to try and make sure and control what was happening there, which clearly, nobody really understood what was happening at the time. We didn't really understand what was happening with COVID that well back on March, that early weekend in March. I'd just like to turn to Jennifer Lyle. Jennifer, I know all of us have been extraordinarily impressed with the early effort to mobilize Operation Protect, which was a program that asked the public to voluntarily supply things like gloves and masks and hand sanitizer and other products that we needed to try and keep people safe. Can you tell us a little bit about what the early days were like there in terms of the availability or lack thereof of PPE and how your team managed to bring together and respond to that challenge?
Yeah, thanks, Mike. And I think PPE is one of those interesting ones where there are certainly things that went right and things that we definitely need to learn from. And not just in the context of PPE, but when we're talking about anything that's a resource where there will be scarcity, where there will be lack of availability. And in some ways, there's some lessons there and parallels to a potential rollout of a COVID vaccine going forward into the future. And the other thing too, when I say there's things that went well and things that didn't work so well, I think we all agree here on this discussion today that we're not done yet. We're not at the end of this journey. This is not a victory lap, but there are things that did go right in BC, and the numbers in those cases do bear us out, because if we look at just the recent data in terms of the number of healthcare facility outbreaks, and we take Ontario as an example, in BC to date, we've had 79 healthcare facility outbreaks, and that includes hospitals, assisted living residences, long-term care homes. But in Ontario, we have over 750 healthcare facility outbreaks over the same time period. So clearly something went well. And PPE is one of those interesting cases. So to understand what happened there, we have to actually go back to January, because even in sort of that mid to late January period, we started getting reports anecdotally from some of our members in the continuing care sector that they were having trouble getting supplies. And so we started doing outreach with members, we started doing outreach with ministry, we started doing outreach with the commercial suppliers. And one of the things that we kept hearing over and over again was our orders are coming in short. We're not getting what we ordered. Things are on back order. We can't get things. Commercial suppliers saying, we are withholding supplies and we're triaging them to the hospitals, and that this is a North America problem. This is a global problem. So those pieces there led us to do our first widespread sector outreach on the issue, which actually took place in mid-February, where we did our first PPE survey. And the results of that survey were really prescient in a lot of ways, because 57% of respondents said that they were having trouble getting supplies. And the number one supply they were having trouble getting was surgical masks. Fast forward to March, we start to receive emails and calls from care homes and from home care organizations, continuing care organizations, saying we've hit that critical shortage threshold. It's been months since we've been able to get supplies in. Our stockpiles have dwindled. We need urgent support. And so that really sort of put our conversations sort of that fast forward when we were talking with ministry, saying this is a problem. At that point in time, I think it's important to remember as well that the long-term care sector, assisted living sector, was not fully incorporated into the provincial supply, and neither was the home care and community living sector. So these were organizations operating without the larger backstop of the provincial government. That's since changed, and that's an important change. But that was the context that we were in that period of time in March. So that really got us thinking at SafeCare, we can't find other commercial suppliers. There's a global shortage. There are organizations that are at real risk of running out. What are we going to do? And so we started thinking, well, where else can we go for PPE? There must be something perhaps unconventional that we can look at. And that led us to thinking, at the same time in March, we're seeing wide swaths of the sector, the economy in BC shut down. And that got us to thinking, well, what about those unconventional PPE stockpiles that we're not thinking of? The N95 masks that are in earthquake kits, the medical grade gloves that are sitting on shelves in restaurants, the hand sanitizer that's sitting in the school first aid kit. What if we can get those items to where they're truly needed right now? And that led to the start of Operation Protect. And so I think it was March 23rd, we formally launched it. And we originally coordinated with the provincial government to funnel all supplies directly into the provincial supply chain, because at the same time, we were building out sort of that rudimentary electronic infrastructure to connect organizations into the Ministry of Health for urgent requests, while other supply chains were being established at a more regional and a local level. And that happened at different times throughout the province. I know Vancouver Coastal was pretty early to the game. So we did that in parallel. But then when we started getting into early April, the situation continued to deteriorate. And that culminated in our April 10th survey, where we found close to 70% of organizations reporting that they were in critical shortage, which means that they had 3 days or less. And you have to remember, around that time, we were going into the Easter long weekend. And so there was a real risk that organizations were going to be exhausting their supplies over that 3-day period. So, at that point, we were calling meetings with all the key stakeholders, unions, WorkSafe BC, industry associations, Ministry of Health, health authorities, to say this is a significant issue and it requires a wider response. We had Operation Protect going at the same time. We had originally, as I said, been diverting all supplies directly to the provincial supply chain. But when it became clear that there were organizations that were not within that supply chain and were in that risk of running out, we pivoted our operations to include responding directly to those organizations who were in dire straits and didn't have an emergency backstop at that point in time. And what we saw in the period of time, in sort of that early April, mid-April period, is we saw a greater response, both in terms of the federal government and the provincial government, and a lot of efforts happening regionally. And those efforts bore out. We saw those results in our follow-up survey on April 23rd, where the percentage dropped from close to 70% to just over 40% were in that 3-day or less supply. And similarly saw improvements again when we did another follow-up survey in August, when we started to see greater supports. We had the Federal Essential Services Contingency Reserve now available to health and social services. In BC, we saw the supply hub opening up to health and social services. The health authority supply lines that were supporting long-term care and assisted living were mature and were well functioning. And so we saw those percentages improve again to only 17%. But over this period of time, we raised 1.25 million items of PPE for the continuing care and the healthcare sector at large. And I think that speaks to both the size of the need that was there, but also to the outpouring of community support. And in some ways, that is a good news story. It speaks to the fact that everybody understood what needed to be done. We were all working towards the same goal. And I have no doubt that made a real difference in several organizations and for the individuals who work in those organizations and who depend on the services those organizations provide.
I just have to put an underline on the fact that you were able to collect over 1 million pieces of PPE in those weeks. I know that your team were getting into cars and driving them around in some cases, or going to pick them up. And what happened during those weeks, I really want people to know what happened to those weeks, because it was really when we started to see the Team BC example start to happen. We had local governments involved. We had companies involved. We had companies that came forward who supplied not only to you, but we had Clorox, for example, provide us with all the hand wipes that were needed for hundreds of care homes. We saw our organization working with Safe Care BC Care Providers, and then of course working closely with the Ministry of Health and the health authorities. And one other initiative that took place during that time it was another operation, was Operation Canucks, when we worked with Canucks Sports and Entertainment to try and second some of their workers that were impacted by the closure of Rogers Arena, and had them actually working, helping some of our care home operators as well. So it really was a fantastic a case of people thinking on their feet during a crisis and working well together. And I hope that everybody understands that, and I think we're so much better off from the work that you did, and Michael and his team as well. To get through those early difficult days. So I'm going to pivot to an area that I know that a lot of us have some thoughts about, but I'll start with Roger, and it relates to the whole issue of visitor restrictions that were implemented very early on. Now, I have to say that BC Care Providers in those early days, and it has a lot to do with not really understanding what COVID was. We said it's time to try and, for the safety of staff and for the residents, we have to ask people non-essential visits to end. So we recommended that. The government quickly went forward with that. We've now had several months where we've seen some of the impacts of those restrictions. in your view, do you think the right decision was made? And how do you think we should address that issue going forward?
Well, thanks very much. I have to say that is a very tough problem. One of the things that we have to do is to make sure that our objective is to protect seniors in the long-term care homes, their loved ones who want to be visiting them, and also workers who are working in the sector. And it is critical that we balance that safety factor, that protection factor, with some of the unintended consequences, in particular in terms of physical health, but also mental health. I think one of the things that when we reflect back, if you look at the Canadian figures, as at September the 12th of this year, there are over 6,700 Canadians residing in long-term care homes who have died as a result of COVID-19. What I'm trying to say is that long-term care homes continue to account for the majority of COVID-related deaths, and in fact, as high as over 80% of all the Canadian COVID deaths at one point. While the figures in British Columbia so far are lower than some of the other jurisdictions, such as in Ontario or Quebec, we must still remember that every death is devastating. It is devastating to families, to loved ones, and to the community at large. So protecting seniors where they live is what we need to do. But at the same time, we need to remember that we have to act in a humanistic and compassionate way to make sure that other ongoing needs of these seniors in long-term care are fully addressed. And that would actually include the whole conversation about the importance of keeping them connected with their families, their loved ones, their care partners, and so on. In the very early days since the pandemic broke, my team at the University of British Columbia in the Faculty of Medicine has started a program called Connecting with Compassion. And what we did was one of the earliest examples whereby we use computer tablet devices and supply them to seniors in long-term care homes to try to connect them with their families and their loved ones so that we know that they can stay connected, at least for the time being, virtually. Now we recognize that the in-person visit means a lot more to that virtual connection. So I think it is really important, and we have now started to see a lot of the work done in this area, to plan for a safe and gradated return of family members and care partners so that they can visit in person. And that involves having a very thoughtful safety plan, having adequate supply of personal protective equipment, and as well as needed, public health kind of guidance and testing if there's any concern at all. So I would agree it is really important for us to continue to focus on these while future waves of the pandemic hit.
Thanks, Roger. I think that this is, again, probably the most vexing issue, and I think that you acknowledge that in your comments, that our sector has faced. And I think that it has been, for family members who have typically hoped to have that connection with their loved ones in a care home, it has been absolutely agonizing. And so I really do think that we have to give as much time and thought to how we address this challenge. And I feel like this is an important enough discussion that I'd like to bring in our other panelists. So Michael, I know that you have been trying to deal with all the various complexities around infection control and managing the risks involved in being in a care home, but I'm sure that along the way you've heard some of the stories of people dealing with the separation, the sort of health and impacts on the people who are being cut off from their loved ones. Can you maybe reflect a little bit upon some of the discussions that you're having with your health authority colleagues on how to address this?
Well, absolutely. And reflecting the previous comments, always in public health where balancing different health outcomes and benefits, and the clear benefits of social connection between residents, family connection, and those visits is so important. And we're balancing that also with the preventing the tragedy of preventable deaths at the same time. And I think that as the pandemic has worn on, we've realized that our prevention methods, of course, need to be sustainable and need to be compatible with good quality of life in the longer run. So we're trying to walk that tightrope, find that balance between prevention of infection and also health promotion. And we've seen at the provincial level and in regional application, the development of policies that allow for more family visits, moving into visits under safe conditions with good education provided to people who are coming into homes. And I think that as we're seeing that those visits can happen safely without introduction of infection into long-term care homes, we can expect that we'll be able to more skillfully achieve that balance of allowing people to have the visits that they need for good health and well-being, allowing them to even have, in some cases, access for healthcare providers or other human services providers to come into homes and safely provide those services while still preventing infection from transmitting into the homes. So it's an ongoing project, but one that we're really trying to make sure that we're seeing all sides of.
I know that when BC Care Providers sent a letter to Dr. Henry on June the 17th, about 10 or 12 days later, they came forward with a new set of policies about reducing the restrictions and allowing a single designated visitor and other criteria they put in there. I think there's been a lot of us who are wondering whether we need to kind of push to the next step. And certainly in places like in Fraser Health and in Vancouver Coastal, we still see outbreaks happening to the point where lessening those restrictions almost seems a very, very difficult challenge. But at the same time, we have to make some adjustments. We've been talking to the BC government about trying to fund tools and resources that would allow people to have visits during COVID. And so I recognize that we're all sort of wrestling with this. I know that if I was to bring Jen Lyle into the conversation on this, Jen, I know that some of the work that you've done is to try and help families to prepare and give them some of the basic tools they need in order to be able to conduct these visits safely. Can you tell us a little bit about what you think safe care and what kind of resources that we should be giving families so they can have these visits?
Yeah, for sure. And I guess from our lens, we look at it as there's certainly the quality of life aspect for those who are living in long-term care and assisted living residents, but it is also a workplace safety risk because we know that by and large, there's really only one way that COVID gets into a care home, and it's through the front door. So I think in looking at that, one of the things, and this is the same whether you work in long-term care or whether you are supporting a loved one in long-term care, but having the knowledge, the tools, and the education to participate safely in that person's life is absolutely critical. And that's why back over the summer, we partnered with family caregivers of BC to develop a series of standardized online e-modules to provide those family members who wanted to go back to be able to support their loved ones in care with the basic knowledge on PPE donning and doffing, things around infection prevention control that were simple and easy to understand, and even more basic things along the measures that you should take in your own personal life so that you can reduce the risk of your exposure while you're moving about in the community. And we've had over 350 people take those courses since they were launched. They're still available. And with the support of family caregivers of BC, we were able to make them free. So having those sorts of tools, helps supplement the on-site orientation that people will be receiving and helps ensure that those family members have a baseline level of understanding of the measures and the things that will be expected of them going into those settings. And I think those sorts of models are things that we can build on so that we can support organizations in welcoming family members back into those care homes and assisted living residences in a way that keeps those workers safe and those who live in those residences and care homes safe.
And I've always, again, appreciated the innovative approach that Safe Care has taken. I do, if our dialogue here today ever gets out to some of our political leaders, federally or provincially, And I have to acknowledge the good work that they have done during the health crisis, but at the same time, recognizing that we can't forget about our seniors and we can't forget about our families, and we have to find a way. If you're going to run an election campaign now, surely you can put together a platform plank that says that we've got to make sure that families are respected as an important part of the care team setting, and that we provide them with the tools, either physical, either instruction and training, but also equipment, iPads for communicating, or even stations where they can meet safely with some physical distancing. And then ultimately, the goal, of course, is to allow them to hold a hand or hug again. And that's something that so many families have been denied since the outbreak began. So thank you very much, Jan. I'm going to turn this to Michael. We have seen, as Dr. Anthony Fauci said in a recent statement, we don't know what we don't know about the novel coronavirus. So I'm sort of putting you on the spot a little bit here, but I know that Vancouver Coastal Health has done some study to try and understand a little bit about the transmission of this disease and this virus within the care setting. Can you maybe tell us a little bit about what you have learned and the kinds of measures that you and your colleagues are using to try and prevent the spread of COVID-19?
Absolutely. A couple of things that I'd like to mention come to the facilities themselves, and then to staffing issues. So one of the things that we have tried to study, and I should mention my colleagues Ben Fair, Joanne Tate, Rohit Bij, who have been leaders in organizing and completing some of this research, is looking at characteristics of facilities that might place them at more risk for large outbreaks. And we found that issues like the design of the home, the size of the facility, the number of residents per room, even when those were studied closely, all sorts of facilities can be at quite a bit of risk for large outbreaks. The main issues that came to the fore were the preparedness of facilities and also some staffing issues that I can talk about. In terms of preparedness, the nature of COVID-19, which we found especially in the older adult population, is that we can have widespread transmission in some cases in a home that goes below the surface, that can go undetected. So while COVID-19 we know very well, unfortunately, can be quite deadly to some older adults, especially with multiple health conditions, the neighbor in the home might be perfectly fine, might have mild infection or completely undetected infection in some cases. So while we've been learning about this huge variation in the health impacts, we've also adapted our strategies. So while we don't recommend asymptomatic testing in the general population, we use that in a targeted way within long-term care outbreaks to try to apprehend the size and spread of outbreaks earlier rather than later. And I think that has helped to avoid some of the larger outbreaks we've seen previously, which not coincidentally were the ones earliest in the pandemic, when we knew less about the transmission of COVID-19 in facilities. And one positive note that I can make in a very empirical and numbers-based way is that the nature of this long-term emergency that we have is that some long-term care homes that have had previous outbreaks have in fact had staff cases a second time or even a third time. But what we're seeing is homes that have experienced outbreaks before are able to limit that outbreak size to just one person. We declare an outbreak with even one case, and currently the most common outbreak size that we have, at least in Vancouver Coastal Health, is the size of one and only one case. So we feel that what we're learning is helping us to prevent larger outbreaks from the start. The other thing that I'd like to mention just briefly is around staffing. We know that protecting staff is important and can't be separated from protecting the residents. There's a lot of risk not only for transmission from staff to residents or residents to staff, but also between staff, who the nature of their work puts them often in close contact, whether that's in teaming up to deliver care, working at a nursing station, or in the rooms that they have available to take breaks. So making sure that staff are well supported to taking time off when they're sick, that staffing levels are adequate, that staff can work in as much as possible in one dedicated unit, and that they simply have the space to practice the distancing that we're all recommending is very important. And I would say that to protect the residents, it's absolutely vital to protect the staff. And we found that through the transmission dynamics we see in outbreaks.
Michael, just sort of following up on this question, have you, your colleagues in Vancouver Coastal, been taking a look into some of the environmental conditions that lead to the spread and the level of threat that the coronavirus causes. I can think of Holy Family, Harrow Park, the lodge up at Lynn Valley were all older buildings that you had to go into. Are things like the circulation of air, the multi-bed wards and those things, have those things been discussed? I realize that you're not in a position to wave a magic wand and find all the resources needed to replace those facilities, but are these things that all of you and your colleagues are talking about?
Absolutely. We're trying to look at and compare the outbreaks in different facilities and look at some of those underlying characteristics. There doesn't seem to be any one thing, such as facility size or the age of the infrastructure, that's a determining issue. We found that when we've taken environmental tests of different surfaces in facilities, and this was a study that was recently published by Vancouver Coastal Health colleagues, including myself, that most of these surfaces, such as handrails, tables, what I'd call stable surfaces, were not contaminated with COVID-19. And where we did find contamination with SARS-CoV-2, the virus causing COVID-19, was actually on some of the mobile equipment. So things like blood pressure cuffs, things like tablets that are used for medication records, those things that might not be subject to the enhanced cleaning that we're always talking about because they're on the go, because they're moving from room to room, have been found to be contaminated. So it's an issue that we're continuing to study. This doesn't mean that the transmission is happening through those objects. That's the next step in the potential risk. But it has called our attention to the need to have extra attention to having dedicated equipment for residents where possible. Certainly during an outbreak, to having equipment that's tied down to specific residents and to directing attention to cleaning of those. And we've seen great uptake of that information in the long-term care homes that we work with.
Thanks, Michael. So, Roger, I want to just pivot a little bit in some of the political direction that needs to happen in order to affect change. You know, you've done a lot of look into some of the systemic challenges. We know that that staffing is a critical issue. We do understand that older facilities, and it's the word that we generally don't like to use, but when I think of some of the old hospital-like environments that led to some very large outbreaks, particularly in Ontario and Quebec, where do you think that the federal government has a role to play, given the fact that they have, the provinces are supposed to be responsible for health, but obviously our Prime Minister likes to talk about fiscal firepower. That fiscal firepower does come from the federal government, and they seem to, so far, to have been very reluctant to put resources needed into this important part of our healthcare system.
Well, one of the things that I've learned very early on, and I continue to learn on a day-by-day basis, is that in order for us to really have a handle and to solve this very challenging problem of the impact of COVID-19 illness on seniors, including those in long-term care, we must take a systemic and an ecosystem kind of approach. And that does involve collaborating across all levels, all the way from, in terms of government level, from the federal government to the provincial and territorial government. I actually am a member of the Task Force on Long-Term Care that the Chief Science Advisor of Canada, Dr. Mona Niemer, has convened back in April. And representing British Columbia and working with my colleagues across the different provinces, we worked very hard, very swiftly to make recommendations to the government. And in fact, I was also recently invited to make a presentation as a witness to the Senate of Canada, to the federal government. What I have mentioned in those instances, and I'll share with our audience today, is that COVID-19 has revealed a fragmented continuum of seniors care across Canada. And that is the reason why it is quite difficult to provide all the Canadians with equal and consistent access to the services that they need based on their care needs as they age. And in fact, in order to solve these particular conundrums, we must make immediate and ongoing solution and action to resolve these systemic issues. And one of the recommendations that I would really provide for our senior leaders to consider is have a national dialogue to explore how long-term care, for example, can be covered within the Canada Health Act. It is something that a number of us across the country feel quite strongly about in order to provide a framework. We also know that one of the things that COVID-19 has shown is that the long-term care sector resources are not at the level that are needed to enable the kind of quality care and social care that is required. And in fact, we know that strategies must be developed in order to ensure there's adequate and sustainable staffing in the long-term care sector. And we've talked a lot about making sure that we have workers working in a single site so that there's no need for them to cross the site. But at the same time, the compensation equity issue and sick leave policies and so on that would allow symptomatic staff to simply stay home has to be there. I think we need the direction to be set first by the federal government, and then really need the collaboration and cooperation of the provinces and territories. It is really important for us to also think about empowering the workers, the staff who are working in the sector. So continual professional training, but in particular in areas such as in geriatrics, in palliative care, and specialized nursing, personal support workers, and so on are so crucial. And many of these initiatives can be done and need to be done at a systemic federal level, and then further filtering down to the provinces and the territories.
You mentioned about a call for bringing long-term care under the Canada Health Act. I have to admit that every time I've heard that discussion with my colleagues in the sector, they recoil a little bit. They feel that it's intended to be an attack on the different private care models that are involved that take care of, in our case, about 2/3 of the provision of long-term care in British Columbia. And I also have to acknowledge the fact that in British Columbia, we've done I think a pretty good job. In fact, significant investments have been made in terms of wage leveling and bringing up any kind of differences between the earnings of people working on the front lines, and I think that's gone a long way to showing that respect. It has had some ripple effects in terms of other jobs within the workplace, but at the same time, it does show a need to really bring those people up to a level of pay that is commensurate with the amount of work that they do. So I don't know if you have any sort of further discussion around the Canada Health Act piece. We've got probably about 10 or 12 minutes left, but maybe you can just explain a little bit what you mean about that one before we talk to the other folks.
Absolutely, Mike. Very briefly, I think what we need to do is to recognize that what I describe as the ecosystem approach, that the operational models of within the sector, in long-term care sector, is very heterogeneous. And there is a lot of work to be done, not just within an individual province, but also nationally. When I spoke about the Canada Health Act aspect, what I'm referring to is to making sure that the kind of services that are needed to supporting seniors and their loved ones in the long-term care sector can be quite equitable across the country, because this is not what we are seeing right now. In British Columbia, I would agree with you that a lot of work has been done in that particular area, but it is certainly not something that we have seen across the country. And I feel very strongly that in order to support and protect seniors in future waves of the pandemic and beyond, this is work that is very worthwhile for us to be thinking about.
So I'm going to bring in our other panelists to really focus a little bit on the workers themselves, who are so vital. I think in some cases, I said off the top that I felt that they are underappreciated during this health crisis. BC Care Providers and others did a pretty good job, and I would say the Minister of Health as well was very good and very vocal about trying to appreciate the incredible work done by our care providers during the health crisis. But Jen Lyle, you've been out there doing training programs to try and reduce occupational injuries, and you've also had a big focus on trying to address mental health, which we know the stress of the COVID crisis has been very challenging. Maybe you can talk a little bit about some of that work and where you think it is in terms of how we can address the challenges of COVID going forward.
Yeah, and I was just reflecting on my colleagues' comments and remembering how even back, I think it was June of last year, when I was before the House Standing Committee on Health talking about violence in healthcare, I used 3 terms to describe the long-term care sector, and it was understaffed, under-resourced, and under pressure. And those 3 terms were true then, they are true today. And I'm so appreciative that you raised the issue of psychological safety, Mike, because I think that's something that, for all we talk about physical safety, we need to absolutely keep that in perspective, not just for the people who are living in long-term care and assisted living right now, but the people who serve and support those individuals as well. And it's been an incredible challenge in the sector. In some ways, it's been our hidden pandemic, the issue of mental health and psychological safety among continuing care workers. One thing that was really interesting, we did a member survey back over the summer, and we asked the question, how likely are you to still be working in the sector over the next 12 months? Because we wanted to get a sense of what was happening, what were people going through, where were their minds at? And one of the interesting things that came forward is that although the vast majority had said that either their plans hadn't changed or they're more committed now than they were before to continue working in the sector, there was a significant minority of respondents who said they were less likely. And the top reason they cited was burnout. And I think as we move into the winter months, we were talking about times when, historically we've gathered families together, we've had big holiday dinners, we've had friends over, we're celebrating. This is not going to be the year for that, where we're gathering in person. And we're still several months into this pandemic with no clear finish line in sight. So that may change as we move forward into the future. And I think it's absolutely imperative that we keep the mental health of staff at the forefront, because otherwise there will be a reckoning for us down the road. And with widespread staffing shortages, we can't afford it, quite frankly. And so that's why initiatives like our partnership with the Canadian Mental Health Association, Care for Caregivers, and the peer-to-peer support line, which is confidential and free, Care to Speak, I think are really important. And there's lots of other examples out there, but it's absolutely vital that we keep that in perspective, because we are talking about a sector that is understaffed and arguably under-resourced and under incredible pressure. And that's not going to change over the next few months. So we need to be prepared for that.
And thanks for all the work that you continue to do on that file. Michael, I met with your colleague. She's well admired by people on our team, Joanne Tate. I spoke to her actually at our Care to Chat, which happened just days before the COVID crisis and the global pandemic began at the beginning of March. And I remember her thoughts then were how to try and keep people calm and centered during these very challenging emerging crisis that was happening at the time. So one of the things that we've had to really do is provide that support for staff, especially when we're looking at short staffing resulting from the single site orders. How have you and the folks at Vancouver Coastal looked at the single site order, and are you of the view that we need to continue maintaining this practice of having workers in long-term care and assisted living only work in one site? And if you do, how do you think we're going to be able to manage the staffing shortages that we're facing?
Thanks, Mike. And I'm so glad that we're talking more about the staff. I think that having had the opportunity to work with some of these staff, I've seen such commitment to the residents of long-term care homes. I've seen staff who are in tears when one of their community members passes away, and similarly celebrating when a COVID-19 test result comes back negative. And that commitment has been so impressive to me. I think in terms of the single site order, when we began to follow carefully the movements of staff who became cases of COVID-19, our findings would probably not surprise most people working in the sector, which were that many of the staff, in particular care aides, were often working at 2 or more sites across the region, often in different communities or even across other regions in BC. And quite naturally, somebody who is a case of COVID-19 is going to present more risk if they're in multiple facilities to the residents that they're dealing with than if they're in one facility only. So we recognized early on that in terms of limiting not just the size of the outbreaks, but the sheer number of outbreaks that we were having, that having staff working at one site and one site only would be necessary. And of course, this was challenging because staff are working in multiple sites because of the very real need to earn a livable income, and that amassing the hours and the remuneration necessary to do that required that they were in multiple different sites. So the single site order helped to quickly accomplish this. It took a lot of technical work to develop the data infrastructure to receive and manage the staff lists, to ensure that staff weren't working in multiple different sites. And overall, we think that it has had positive impacts in terms of health protection, limiting the number of new outbreaks. When people do become positive for COVID-19, which we expect to continue during this pandemic, their exposure is limited and better known, better understood under the single site order. Naturally, this is something that has been a challenge for the sector to adapt to. We have heard that staffing shortages can accrue, that filling shifts and so forth can be a challenge. We've seen most of the sites that have involved adapting very well to this, however, and even during outbreaks, staffing has been maintained. One thing that we've committed to at Vancouver Coastal Health is that during an outbreak, when a site has been short-staffed, we've been able to provide staffing from Vancouver Coastal Health ourselves to fill those gaps when necessary. And we think that reciprocity is very important, that under this order and under the high demands of outbreak prevention and control, that we're able to provide that support. So that's something that we've been able to do to help out the long-term care homes that we partner with. And I think that continuing to find solutions to staffing that are long-term and sustainable is going to be very important.
Thanks very much, Michael. So to all of our panel, I'm going to give you 60 seconds to answer this question. Is BC in COVID, has it been a success story? So I'm going to go to Roger first.
Absolutely. Thanks, Mike. I would say that in BC, the situation is a success story in the sense that we actually have taken very swift action. We take it very seriously for the protection of seniors, their loved ones, the workers, and everybody who is connected to the sector. I think I am cautiously optimistic as we walk into the fall season and as we face new waves of the pandemic, that together we actually can make a difference.
Thanks very much, Roger. Jen Lyle, has this been a success story in BC?
I think the answer is it depends. So, if we look at it in terms of numbers, 79 versus 751, there's obviously something that went right there. So I think in that sense, there were things that did go well. And I think for us going forward, what we need to understand is what went well and why. Because we can't just repeat the same actions we did in March, because the context and the situation of March is not the context we're in today. So that's why I think the answer is it depends. We're still in the middle of the story. There's still a lot of chapters left to write. But I'm hopeful that through this great collaboration, the larger team approach, that we will be in a position to address whatever the fall brings and what comes after that.
Thanks very much. So Michael, you get the last crack at this question. Has BC been a success story during the COVID crisis?
Thank you. I'd say that we've had a strong start, but this is going to be a marathon. We know that the terrain is going to change. We're coming into our first full winter, our first influenza season, where we have an overlapping pandemic of COVID-19. I think that the issues of sustainability of some of our measures are going to be challenged, and we'll need to only strengthen our efforts and adapt them as well. But so far, I think that our efforts have been successful, but we really need to continue to monitor the situation and be ready to adapt.
So with that, I'm going to close up by just thanking all of you. Dr. Michael Schwant from Vancouver Coastal Health, Dr. Roger Wong from the Faculty of Gerontology, in fact, Faculty of Medicine at University of British Columbia, and Jennifer Lyle, CEO at Safe Care BC. I want to thank you for all the work that you've done during this COVID crisis and being so engaged on really one of the most defining times of our generation. We've had to really look after the public health and the public interest here, and you've all played a very important part in it. And I think I'd also like to acknowledge all the people who've attended here to this conference. Obviously, our online BCCPA 2020 virtual conference is the first time we've ever done something like this, but I think we've had some fantastic presentations and important conversations happening here this week. And I also want to acknowledge all of our fantastic team at BC Care Providers, and as well our colleagues over across the hallway at Safe Care BC for all the work that they've been doing and really fighting hard since the pandemic began. And I think it's the Team BC approach that we have taken that has really, I think, made a huge difference here. And I can't emphasize that enough. It's the work that we've done together. It's the work that we've been able to do with our Ministry of Health and our colleagues and partners in the public sector health system. It has been remarkable to see all of us pull together, think outside the box, and really try and get a handle on the COVID crisis here in BC, and I think we should all be very proud of that. So thanks to you, our delegates, and I hope you get to watch the rest of the programming today, and we'll see you on the other side, and go to bccare.ca, and we'll continue to share our information and dialogue there from this conference. So thank you very much. I'm Mike Klassen. Have a great day.